Okay, good morning to all. I'm Dr. Deena Zimmerman, as we said, originally from the States, and I want to talk to you a little bit about my international breastfeeding journey, going from one country to another. And it all started out when I gave birth to my first son. Everything I had learned in medical school could be summarized in 2 words. It's good. I knew nothing. Fortunately, he knew something. And I fell in love with breastfeeding, which was something I would have never imagined before that, because my decision to breastfeed at that point was completely intellectual. Motherhood changed me completely, and it became like a gut feeling. When I was in my 2nd year of residency, I was doing my nursery rotation, and our hospital had an IBCLC, not that I knew what that was, but we worked together in the nursery, so we became friendly. And she explained to me what it is to be an IBCLC. And I said, okay, breastfeeding is important. I'm going to go get that degree, because then MDs will know what breastfeeding is, okay? Because they'll see it and they'll ask me, and they'll see that doctors can also do things in breastfeeding. And that's how I started being an IBCLC. I took my first exam to be certified while I was pregnant with my 3rd son. Okay, this is how I remember my life through when I was pregnant or having children. And I became an IBCLC. Around the time that they were forming the Academy of Breastfeeding Medicine was exactly when I moved to Israel. So I kind of missed it in transit, because I was busy involved with trying to get kids used to new schools and all those kind of things. So I knew something was going on over there in America, but I wasn't really part of it. I was more involved in the Israeli scene. At the time when I moved there, there were exactly 2 MD IBCLCs in the entire country. And one of the fun things about living in a small country is it's easy to become a national expert, because it was just the 2 of us. And just at that time, the Ministry of Health decided that they were going to do a national training session for the nurses who work in our public health clinics and do the well child care. And I literally went from one end of the country, from Eilat in the south up to the Golan in the north, giving lectures on breastfeeding. At this point, I had my 4th child, and she came on lectures. Until this day, people remember, oh, you were the one who lectured to us while you were breastfeeding your kid. So I, did that for a number of years. I also met the local La Leche people here in Israel. And for about 3 years, we put out a journal in Hebrew about basic breastfeeding knowledge, okay, to be used for doctors and other health workers. And when I moved to Israel, every single person who was involved in lactation had an English-speaking accent, primarily American, okay? One of the things I'm really happy to say now is most people speak in a native Israeli accent, okay? So there really has been a shift over the years of the country learning about breastfeeding. The example I always give is when I first moved here, there was no word in Hebrew for rooming in, okay? Now, not everybody gets it, but at least there's a word for it. So I view that as having made some progress along the way. I think the next big step was when I worked as a community pediatrician for the first 20-something years I was here. I had an MPH from the States, and somebody I met through pediatrics dragged me to come work with her in the Jerusalem District Public Health Office. And I did that part-time together with pediatrics. And that was an opportunity to start doing things on a more broader level, on a population level. One of the things that we did accomplish over those years, because my boss was a neonatologist, a pediatrician, as well as being in a public health person. She has 3 boards. So she was open to ideas about doing studies about things that had to do with newborns. And one of the studies we looked at was we had a policy in place that every woman was supposed to get lactation consulting in the first day of life and the second day of life. However, we showed that at least in the Jerusalem district, that only happened to 40% of the women saw anybody once, okay? So it was interesting to look at a public health service. It's now 5 years ago, I moved into my current position, which is, I am the head of the maternal, child, and adolescent department of the public health directorate. I would have translated division, but they chose directorate, of the Ministry of Health. And this was really a golden opportunity to try to do something for breastfeeding. Because the person who writes the policies for these public health clinics that I've mentioned, that's where everybody in this country gets their well child care from birth to age 6. I will mention they get it free of charge. There's a lot to be said for having national health insurance and people not having out-of-pocket costs. Definitely something I learned in the switching between the two countries. And one of the big things that we did over the last couple of years is we all know that there is a problem when people are getting conflicting messages, okay? You know, this nurse tells you to do this and this doctor tells you to do this, and it just gets confusing and it's not very good. So we managed to write instructions of what one is supposed to be going over with breastfeeding in mothers at every visit, okay? I kind of took the idea of anticipatory guidance from the United States that I had been brought up with a pediatrician, where you always had the topics you discussed at the 2-month, 4-month, 6-month, 9-month, those visits, took that concept, applied it specifically to breastfeeding. And this is national policy, okay? This is what every single nurse who is doing public health and talking to mothers is supposed to be saying. We actually had a program to, you know, we made up a standardized set of PowerPoint slides so it would also be taught the way it was meant to be done. And it's had a big influence, okay? Are there ever times that things aren't exactly the way you wanted? Of course, this is the real world. But the fact that there is a standard and that you can show people the standard and you can refer to the standard and you can do like supervision based on a standard, I really do find that that has made a significant contribution to what we're trying to do in the world of breastfeeding medicines. I was blessed. In my 5 years in this position, I have worked under 3 different heads, okay, because there was a certain amount of turnover due to Corona. I started this job exactly a month before the epidemic broke out, okay? So you can imagine working in the public health service that many other topics were in the forefront. However, despite it all, we've been working on keeping breastfeeding front and center, and the current head of the public health service is very much behind me in the sense that she does see that this is an issue of public health. And what we are working on at this point is trying to have real work plans to try to bring baby-friendly hospital to Israel, okay? At the moment, it does not exist. We have one hospital based in East Jerusalem, which was almost there, all right? And I'm really hoping that they turn out to be the first, all right? We've met with them already twice to see how we can help them. But part of the issue is first we need some sort of national certification and stuff like that. But one of the things that we're definitely pushing forward in an organized way is baby friendly. A second thing we are going to start working and start talking about is the code, okay? Because we have pretty much no provisions for the code. According to the official book of IFAN, we have 0 provisions. I disagree. I think we have a little bit, but certainly not enough. And we're trying to work getting that into the public sphere on many levels, also in terms of professionals. Every single pediatric conference we have here, you know who sponsors it. And just bringing the issue up, it's like, what are you talking about? It has no influence on us whatsoever. So I was blessed with being sent in a professional capacity to the global conference, okay, that was held last year in Geneva, and came back with a lot of action items, which we're working now into bringing into it. And I think the tact that the WHO is taking at the moment in terms of tying it into digital marketing and also other not so good health behaviors such as alcohol, smoking, and whatever is going to give us a way to, yes, get it going. Because when you first just brought it up that it's only breastfeeding mothers, we're still in the mentality of, oh, we don't want non-breastfeeding mothers not to feel bad. But by putting it in the thing that this is talking to parents of all children who also need safe, not ultra-processed foods, okay? I think we're beginning to have possible partners in conversation. So those are the things that we're trying to do on a, public health level. On a more drilled down level, about 6 years ago, we founded the Israel Association of Breastfeeding Medicine. The idea was to have a local group that could be working on our local issues. And I understand from one of the my co-workers on it, and really the person who pushed it forward, Michal Mankowski, who Eileen knows and stuff like that. I understand for her, we were somewhat of an inspiration for Europe to follow us as well. Because it's now the Europe Academy of Breastfeeding Medicine and Israel, okay, we're in their bylaws there. Because it is important. I think that's an important thing for the ABM as an international organization to realize. It's really important to have the international overview, but you also need some workers on the field. And there really is a difference between one country and the next, okay? You would think it's medicine, it's human beings, we're all the same, what the difference is, but it's not, okay? And I think I have, the privilege, having lived in 2 countries, to really experience when it's not, okay? And how you have to think about your local issues and not just the bigger issues. And the one other project I've been very involved with that's also been very interesting is founding Israel's first milk bank. My predecessor did the entire 10-year pregnancy of the milk bank, and I exaggerate not, but I was the person who was actually present at the birth, and it was a very difficult birth. But we do have a milk bank. It has now existed for 3 years. We're busy in the negotiating to continue it. It is government funded. Okay, so people who are using it in hospital at this point, it's just part of their possible, hospital care. They do not have to pay for it. So that's kind of a, I think, 20-minute summary of the kind of things that I've been doing since moving to Israel, a little bit of my feelings about what it is to be in 2 countries, and I'm totally open for any questions on anything I said or anything I forgot to say. We need the brave person to ask the first question. That's always what's the issue.
Well, thanks, Dr. Zimmerman. That was amazing. And I saw for those that had their cameras on, I saw lots of smiles and lots of nods and lots of things are resonating. And Lori, why don't you go ahead and go first? I see your hands raised.
I'm going to break the ice. So how do you get doctors in Israel, so maybe in the rest of the world, to take ownership of providing direct breastfeeding care?
Okay.
But this is not just for the IBCLC, but this is a responsibility of the profession of being a doctor.
Right. So I think where we've made the biggest impact along that was actually with the Israel Association of Breastfeeding Medicine, Because what our number one issue was that we were going to do is we were going to make official training of doctors in breastfeeding medicine. And we made 3 levels, okay? That the first level, which was heavily based on the idea of what every physician needs to know, but we made our own version of it, but it had that concept in mind. It doesn't matter what specialty on, this is what you need to take. I jokingly refer to it in-house as this is the first do no harm course, okay? And we have now trained 500 doctors in that course, which in the amount of doctors we have in Israel, I don't know the exact percentage, but it's a real percentage. Most of them are young doctors. Most of them are women who've experienced it themselves, and they don't want it to happen to other people. So I think one of the things, at least here, that is causing a change in ownership is women coming into women have always been in the medical field, but I'm saying women who are in the medical field who are realizing, wait, this is something I should know as a doctor. I want to know it, and I'm going to do something about it, and having something relatively easy to do about it, okay? Our course is now online, okay? We have 2 then Zoom sessions so they can ask questions. And one of our Zoom sections, the last one, is a joint meeting together with an IBCLC. And we put the stress there on teamwork and what is the IBCLC's role and what is the doctor's role. And a lot of that is important because many doctors don't do it. There's a feedback I get because they don't have the time. But if they realize that I don't have to find the time in my practice, if I identify the problem and I have somebody I know and I trust that I work with, I can make it fit into the 5-10 minutes I have a patient, okay? With the knowledge that I have and with the mutual understanding with the IBCLC. Like we're talking the same language, we're using the same things. So I think that's made a big contribution. The second step, we're now at we're training the second level now. Our first cohort of second level trainers are starting right now. That's about a 2-year training, which has a lot more clinical stuff based in it. And I see what our graduates are starting to do. I mean, one of our graduates of the first course works in one of the hospitals, and she, together with another colleague, also a graduate, have made a breastfeeding service for the entire hospital. Okay, it's not just we will give you lactation or breastfeeding support if you are in the newborn or the NICU. We will give it to you also if you came in surgery or in the emergency room and stuff like that. So I think it starts to some degree with the next generation, but I'm very optimistic about it because, like I said, we've only been around for 6 years. All right, so okay, Yvonne, I saw your hand up.
Yeah, good morning, Deena. I'm a little bit of a similar pioneer in New Zealand, being the first breastfeeding doctor that went there at the beginning of the 2000s. And there were a couple of things that I actually faced difficulty with and continue to notice that our younger doctors that are getting involved in breastfeeding medicine have a difficulty with, is sort of integrating in with IBCLCs, midwives, nursing, the whole area that's not doctors that previously owned breastfeeding. And certainly in New Zealand, the first 6 weeks and lead maternity care now really excludes primary care medicine. And there may be a few obstetricians involved for cesareans and high risk situations, but primarily it's a midwife driven service. So our government thinks that there's no breastfeeding problems outside of the first 6 weeks of life, and that the midwives are actually capable and being paid the tremendous sum they are being paid, which covers breastfeeding. So we've never got to anywhere really to recognize our field, and we're working on that. But that was one thing. And the other thing that you touched on was the code compliance and code compliance was something that when I started, I was very interested in, and there was no avenue to kind of even report violations of the code. And I'm beginning to believe, and others on this call know, that this is very key, that all our good work and all our effort, if we can't get our profession to realize that we are inadvertently participating in the maybe or overtly participating in the marketing of something that goes against all our knowledge and all our skills. So anyway, those are my two comments. I'd like to hear what you have to say.
Yeah, so first of all, as far as you said that other professions, you know, were there already, this is where I think I had an advantage. As I said, breastfeeding in general was in an infancy. They were just starting to get nurses in it. Just, you know, there were 5 IBCLCs, 10 IBCLCs in the whole country, all of whom, as I said, had moved from America. And I'm friends with all of them, okay? The fact that I gave those lectures to all the nurses, they know me, you know, as an IBCLC long before they know me as a breastfeeding medicine, okay? So I think I had on a personal level a lot of credibility that I was just lucky to have. All right, that's number one. Number two, we do have a bit of what you're saying because the nursing division of the Ministry of Health does not, right now, Israel does not recognize IBCLCs as a certification because in order to be a professional certificate, it needs to be credentialed here in Israel, and they will only credential things that have a degree-based program. There is no degree-based program in lactation consultants yet in Israel, so your IBCLC doesn't count. The nursing department therefore made their own Israeli lactation consultant definition for nurses, okay? And yes, for nurses. So the way that we basically circumvented that was by founding the Academy of Breastfeeding Medicine and making our own 3 levels of certification, and have been working together with the dietitians to make their level of certification. So we've been keeping the pressure on that, but it is an issue, and I think doctors need to sit up. And yes, I was luckier than you just in terms of the timing that I can. As far as the code is concerned, attending that conference in Geneva was amazing, okay? Because they really talked about not the code, what do we do? And I'm just going to throw out there that maybe that should be one of the groups that we do as an ABM to get people in different countries to kind of like brainstorm. We can even like get people from the WHO, they're really helpful in terms of this, to think, how can the ABM work on getting the code into professional societies? You know, it's a 10-year project, but I think it can be done. And I think if we do it as an organization and we do it internationally, we have better than that doctor in that hospital trying to get their colleagues to understand why don't want to take the form of the company money. So I'm throwing a challenge out there. And Eliane, you were the one who wanted to speak, so the challenge goes right to you. As president. You had a question? You had your hand raised.
Yes. What I was asking myself, I know a little bit of the situation in Israel, how you started, because I have good sources there.
Yep.
And you are with us in ABM, which I think is amazing. One of the things what amazed me and what was I think very key, that you also have a good relationship with the pediatric or the physician associations. Can you elaborate more on this? Because this is where we are struggling. For instance, in the countries where I am working, Netherlands and Germany, that, well, they think we are just odd.
Okay, so I think once again, I kind of fell into it on a personal level. When I moved to Israel, in addition to being very active in breastfeeding, I was very active in pediatrics in the community, because when I moved here, The only pediatricians who were considered to have any standing were those who worked in the hospital. If you worked in the community, you were by definition stupid. And I had worked in the hospital as a primary care physician. I chose to be a general pediatrician, not to do a fellowship, because I wanted to do the entire child and not one particular body part. And I just was like so taken aback. Like, I think what I'm doing is important. What's going on here? So over the 20 years, things have changed in terms of understanding pediatrics. And I was involved in that, so I know all these people. So I think one of the things is personal contact does make a difference. Okay. And I was lucky.
It might also be easier in smaller countries than
Yes.
in bigger countries, I suppose.
I think so too, but I think in bigger countries, it is possible to scale it up, okay? To think how we get people to infiltrate these things. You know, sometimes we go straight to the head and the head was like, what are you talking about? But if we go and we think about the younger generations who are training as pediatricians, who have heard about breastfeeding medicine, and then they become members of this, well, today's members are tomorrow's leaders, okay? So I think a lot of these things we need to be looking in the long-term picture. And, you know, looking back at my professional career, there was no plan here. You know, it was kind of like, I knew I was moving to Israel. I knew I found a job. The best kind of thing to work in at that point was working in the community as a pediatrician. I ended up in public health because I met somebody through pediatrics. Okay. And I ended up in the, you know, in the Ministry of Health. So as a religiously believing person, I kind of believe there's somebody out there who had a plan that I didn't have. Okay. But I do think the being in lots of different things gave me a perspective from lots of things that gave me the ability to touch different organizations in a way. And maybe the thing that can be learned from that, all right, maybe not every individual person is going to have as crazy and as an eclectic background, you know, as I've done, because even in pediatrics, I like breastfeeding and emergency care, you know, like, what do they have to do with each other? I don't know. I like them. I like variety. You know, but I do think as a group, okay, if we think about, okay, we are united together in breastfeeding medicine, we know each other from breastfeeding medicine, we come from all kinds of different things. So let's see how everybody can, I'll use the word infiltrate, but how everybody can do their little thing and their thing, but having people behind them. Because I think the biggest challenge in a bigger country or whatever, if you're the one person, you know, in the wilderness and you feel yourself, it's overwhelming. You know, how am I going to change everything? But if you know, I have people at my back, even if they don't happen to live in my country, okay? That already makes it different. And if I don't have to reinvent the wheel, if I know that we as an ABM, as an international organization, have an overall plan, like I was saying with the code, how we're going to do it, we have the support we need to keep the energy to, you know, be the Don Quixote and fighting the windmills and stuff like that. And also we'll have the skills and we'll have the materials, okay? There's no reason each person has to sit down and write things from scratch, all right? We can take something and then translate it. We can adapt it. We can make it appropriate, but the more, and I think this is something ABM really can think of as we work more and more to try to think how we have an international impact, is kind of have the toolkit, okay? This is our code toolkit. This is our BFHI toolkit. This is our how we deal with professional society toolkits. So somebody who's feeling that passion, who is young enough to do it, says, I want to do it, but she knows I'm starting from step 3 and not from step 0.
Thank you so much, Deena. That was really inspiring. Thank you. And there's a lot to think about, and I thank you so much for the contribution, because I really think this was very helpful.
Mm-hmm. Okay, it was also a lot of fun. And it was very nice to see a lot of people here I know. And it's nice to see you, what for me is a decent hour, because on the protocol committee, I'm usually on at 11 o'clock at night. So this is a pleasure. And I'm really hoping that I get to see you in person in November. Let us all pray that the world circumstances will allow that to happen.
Indeed.
Very good. Thanks. Thank you for the opportunity.